All right. Well, welcome everyone to our On the Pulse series. I am Chris Fortman, the CEO at the Minneapolis Heart Institute Foundation, and I am so glad that you all made time to join us. Just a little background before we get started on the Minneapolis Heart Institute Foundation. We are a separate independent nonprofit organization, so separate from the Allina Health System, separate from the Minneapolis Heart Institute. This visual kind of gives you an idea that our mission is to improve cardiovascular health through innovative research and education. You can see those in the top circles, and with the result being improving clinical practice with the dissemination of those research findings. So we have been in existence for just over 41 years doing this good work. So what is this work in research and education? We have over 200 active studies touching over 2,000 patients, and half of those studies fall into industry-sponsored clinical trials, allowing medical devices into the clinic to help our patients, and the other half, those studies are physician-initiated research. So the most important pressing questions that our physicians feel need to be answered, we have the resources to support that research. Education is a critical part. We have a paid internship program with over 200 alums here at the foundation. Most of those alumni are currently practicing physicians or in medical school. And during the summer, while those students spend their time with us, they are doing real research with our physician mentors and our research staff mentors, and many end up being authors on manuscripts and presenting at national conferences. Also in education, we provide CME and community education and publish over 200 peer-reviewed manuscripts annually. So in MHIF current updates, some exciting news. Our very own Dr. Paul Saraja presented a much anticipated late-breaking clinical trial at this year's ACC, the American College of Cardiology Conference. This trial, called Triluminate Pivotal Trial, showed that transcatheter edge-to-edge repair using the TriClip system is safe and effective in patients with symptomatic severe tricuspid regurgitation. The intervention reduced the severity of regurgitation and was also very safe, with a low rate of major adverse events around the time of the procedure. To quote Dr. Paul Saraja, he said, "We feel these results are very meaningful for a highly symptomatic population whose quality of life is impacted by tricuspid regurgitation. And with the excellent benefit to risk profile of the system, we feel that a historically untreated population will now have a treatment option to improve their quality of life." This groundbreaking research was published in the New England Journal of Medicine as a manuscript and was even picked up by news organizations like the New York Times. And as I mentioned earlier, the Minneapolis Heart Institute Foundation is a 501c3 independent nonprofit that relies on philanthropic investments that come from community leaders like you. So I want to take a moment to say we are grateful for all of you who make this work possible. Thank you so much. It is my pleasure to introduce Dr. Brilakis. Dr. Brilakis received his medical degree from the National University of Athens, Greece, and trained in internal medicine, cardiovascular diseases, and interventional cardiology at the Mayo Clinic. Dr. Brilakis has authored and co-authored over 700 manuscripts and has written 2 textbooks. He is lecturing and proctoring at several institutions in the United States and abroad. And I would also like to introduce Dr. Vinnie Bapat. Dr. Bapat earned his Bachelor of Medicine and Bachelor of Surgeon degree, followed by Master of Surgery and Master of Cardiothoracic Surgery degrees at the University of Bombay in India and King Edward Memorial Hospital. Dr. Bapat was a cardiac surgeon at New York Presbyterian Hospital and professor of cardiothoracic surgery at Columbia University Medical Center in New York. He also previously served as professor of cardiothoracic surgery at Guy's and St. Thomas's Hospital and continues to hold that position as visiting professor. Dr. Vinnie Bapat joined the Valve Science Center team in June 2020, bringing his extensive expertise as a cardiothoracic surgeon and innovator in treatment of heart valve disease. He also works directly with patients as the chair of cardiothoracic surgery at the Allina Health Minneapolis Heart Institute. And with that, thank you very much. And here are Doctors Brilakis and Bapat presenting on life after CABG.
Thank you so much, Chris, and thanks for the opportunity to participate at the On the Pulse seminar. This is a special one we've actually trying to do for a very long time, even before COVID, but then things changed. But I'm so excited today that I'm joining with Dr. Vinnie Bapat, who is the chief of our cardiac surgery department, very established, very senior surgeon, to discuss about life after CABG. So actually, life for many people is what is the birth and the death, but some people do get bypass. And that's a major event, and that's why we like to save life before and after bypass. But what leads to bypass, and why is bypass such a prominent modality for treating coronary artery disease? I think Dr. Bapat is going to talk about this too, but these are actually fairly recent developments. The first bypass was done a little over 60 years ago. So we haven't been doing this for hundreds and hundreds of years. And actually the intervention, the stents, the other modality for opening arteries, has been around for a little over 40 years. So these are all fairly recent developments, but have been dramatically improving over time and giving options to patients who have coronary blockages. So this is what leads to bypass. This is a nice, smooth coronary artery. This is when the cholesterol starts building up inside the artery. If it keeps on progressing, then it can create narrowings. So it's a simple thing. We have a pipe. The pipe gives blood to the heart muscle. The pipe gets plugged up. That's a problem. If it's completely plugged up, that gives a heart attack. And this is how it looks like. This is the artery in an angiogram, which is a procedure in which we take the images of the arteries of the heart. And it's supposed to be nice and smooth and go to all the part of the heart. But if you look on the other slide here, the artery starts but then stops. And this is an example of a patient who has a sudden occlusion, a heart attack. But this can happen also slowly over time. Doesn't necessarily have to happen acutely as in the heart attacks. So when this happens, there are two ways to open the artery. One is with doing balloons and stents, and the other is with coronary bypass graft surgery. But this is just one part of the equation. Getting the blood flow restored is one part, but to keep it flowing, as we'll discuss, that's the main theme for today, is that you need other things. You need to work on your lifestyle, take medications. This will prevent the bypasses or the stents from closing down again and causing more problems down the line. And who gets bypass? And I think Dr. Bapat will talk about this as well. But in general, bypass is a modality we use for patients who have complex coronary artery disease. So if you have only one artery blocked, one of the three, we typically do stents. But when you have multivessel coronary artery disease and the patient is a good surgical candidate, doesn't have any major comorbidities, bypass is the preferred modality and provides excellent long-term outcomes. So I'm going to stop over here and hand it over to Dr. Bapat, who is going to talk about how do we actually do the surgery and what to expect during the surgery and after the surgery. And then I will finish with some comments about how to optimize the chance of your bypass graft staying open. So Vinnie, thank you so much again, and looking forward to hearing more from bypass from you.
Thank you, Dr. Brilakis. Excellent introduction to that. And so my talk is essentially understanding CABG or bypass. It's very important that if you understand it, it's easy to cope with it. We're going to discuss a couple of things before diving into what actually bypass is. So background, presentations, investigations, how do we make decision that when to do bypass or not? Because many times patients are surprised, I was absolutely fit and well, and now I suddenly need this major operation. And slightly about the history as well. As you know, Minneapolis was one of the groundbreaking places where a lot of things happened in heart surgery. And then understanding surgery and post-surgery. So first of all, it's good to know that it's actually the commonest operation performed all over the world. If you look at any major or even a small center, CABG forms around 60% of what we do every year. And unlike the heart valves, the good thing about CABG, if there could be one, is that it's done on the surface of the heart. So we don't have to open the heart per se, which makes the operation slightly easier. Excellent outcomes again, as Dr. Brilakis mentioned, the first one was done in 1966. But since 1980s, this has really progressed rapidly and has become a very standardized procedure. And one good other thing is it's a short recovery. So presentation, it really varies from patient to patient. And some of you must have had CABG before, some of you probably are waiting for it or you want to understand about it. Many patients are asymptomatic. That means they are feeling fine, they go for a checkup, there is some change, or they go for another major operation and then something's wrong on the ECG, and that's why they are referred to us and we find there are blockages, as Dr. Brilakis has shown before. Majority of the patients, however, have what we call as a stable angina. That means they get pain on exertion, unusual exertion. Some patients also get pain sometimes after food. That is, we call it postprandial angina. However, many patients present with what we call as unstable angina. That means angina at rest. Your heart, when it's not doing a lot of work, it's not getting sufficient blood supply. These are the patients we usually perform either of stenting or CABG as an urgent operation. Some patients present with heart attack, either past or present, and then rarely with complications after heart attack. Some investigations are must, and as the science has progressed, we always do an echocardiogram. For example, one echocardiogram here shows function of the heart. Here it also shows heart valves. In this particular patient, the mitral valve was leaking, so we need to address that at the same time. And in this particular patient, both the valves were leaking as well. So again, even if you come for a bypass operation, we may find additional things and we need to fix those things. We also need a roadmap, and this roadmap is very important. Today, we don't travel anywhere without GPS, so think about it, that probably heart surgery was probably the first GPS version of what we do. So this is a coronary angiogram. Why we look at it, this is, although it's a two-dimensional image, when Dr. Brilakis does and his team does angiography, they do angiography in multiple views, and we try and understand out of the major 3 arteries and the branches where the blockages are. But more importantly, we also get an idea of how is the artery or the vessel beyond the blockage, because that really is critical for a surgeon to know where to open and do the bypass and what the quality is. This is again one of the patients where you can see there's a parrot beaking or a very narrow left main artery. And again, this is one patient where one branch is occluded. So these are the reasons, these are different examples we look at. Some of you might have had a CT angiogram before valve surgery as well. And on CT, we can pick up now, not as good as coronary angiography, but maybe in future we can make it as precise as in one example shown here. This roadmap becomes important. As you can see on the right side, one of the arteries is like a corkscrew. And this surface anatomy becomes very relevant for a surgeon to differentiate one branch from the other. And I think this is really critical roadmap for us to do a successful operation. Sometimes we also do perfusion scan. The reason to show you this is, if there is a complete blockage and a big heart attack, it's important to show that that area is viable. That means there is merit in doing CABG. We don't want to make the operation unnecessarily complicated or prolonged if the area we are going to graft is not going to get benefited by it. This is just to show you that in those patients, we now do a lot of perfusion MRIs and perfusion CT scans to show the scarring as well. And some of you might have undergone stress test. Again, this is a very established and a commonly performed test. It essentially tells us the supply and demand imbalance in your heart and its blood supply. So the decision making, as Dr. Brilakis mentioned earlier, it's a team approach. It's not one person, you go to a surgeon, so he says surgery. So cardiologist, cardiac surgeon, and when your heart function is below 30%, we also involve heart failure specialist. And then we discuss how to sequence these 3 options: medication, stenting, and coronary artery bypass surgery, so that it helps you entire lifetime. So lifetime management is now critical when we make these decisions. When is CABG preferred? As Dr. Brilakis mentioned earlier, if all three arteries are involved, if the main artery, left main artery, and you're on the younger side, we prefer that. Patients who are diabetic, patients who have diffuse disease where stenting, you may do stenting but may need a very long stent. And again, patients who have had stents before and they are not working anymore. Similarly, this is just an example to show you one of our patients who had left main stenting and it developed an in-stent restenosis, so underwent coronary artery bypass grafting. But stenting also is preferred over surgery when, as Dr. Brilakis mentioned earlier, one vessel, two vessel, more proximal disease. Really, honestly, it works so well that it's a preferred type of treatment. Even left main disease, the science has progressed so much that in right patients, you can even open major blockage in the main artery or the main trunk of the artery. And more importantly now, when I was training 20 years ago or 25 years ago, a lot of CABG patients used to come back for second operation. Now, with advances in cardiology, we rarely see those patients. Most of the patients undergo successful interventions on their bypass grafts or the original arteries, and they rarely need a second coronary artery bypass grafting. Timing of surgery is important. Sometimes you have a neighbor who has had a bypass surgery and you feel, well, he could wait for 3 months, but why are you telling me I need it tomorrow? So again, we divide them into 3 segments. Elective, that means you can plan your surgery in the next 3 months. Urgent, that means if you are admitted in the hospital, preferably within the same hospital stay, we do your surgery. And then emergency, that means if you present with a complication, we usually do not wait, but operate as immediately as possible. So again, very important in terms of deciding and understanding that 5 fingers are not same. Why do we do this bypass surgery? Is to restore the blood flow to the heart, of course. More importantly, the chest pain which you get is going to go away. Quality of life is going to improve. And in certain patients where the heart function has gone down, it helps to improve or preserve the heart function as well. And again, indirect benefit, of course, is lower the risk of heart attack. It's important to know the history, again, and very briefly, again, Dr. Brilakis has shown a beautiful timeline. All this started in Russia and then in Argentina. Dr. Faularo is a very famous surgeon in our field. And these are the pioneers who essentially developed this technique. And Dr. Dudley Johnson from Milwaukee actually popularized it and standardized it in 1980s. Lot of patients ask us, why do you approach the heart through midline? Again, this is just to show you the heart has got right side and left side. And when you need to address all these 3 vessels, the best way always is to approach from midline. If it's only left side, I'm going to show you some pictures later, one can do what is known as a mid-cap procedure. But in general, this is the safest way and the best way and the quickest way to do a bypass surgery. How many bypasses do I need? A lot of patients ask me triple bypass, quadruple bypass, and this is very important. Heart has 2 arteries, left and right, and the left divides into 2. So essentially, I have circled the 3 main arteries of the heart. If all 3 are involved, you're at least going to need 3 bypasses. If the branches are big, you may need 4 bypasses or 5. But more importantly, we look at how big the arteries are. If usually the arteries are smaller than 1 millimeter, we do not perform bypass because it probably is not going to last that long. So again, this is very individual approach to each patient. Bypass surgery is of 3 parts. One is harvesting the conduits, that means the vein from the leg or the artery from the hand, then connect you to the heart-lung machine in most of the patients, and then actual operation per se. So very quickly, in old days, I would say that we used to open the leg completely and then close that whole leg. But now all the veins are harvested endoscopically, especially at Abbott Northwestern. And you can see that vein can be beautifully harvested and there are rarely any issues with the incision. You can start mobilization very easily as well. Similarly, we use a radial artery in some patients. And as you can see here, in past, we used to make an incision on the forearm, but now that also we do at Abbott Northwestern endoscopically and very successfully. So again, very small incisions, and you don't have to worry about healing of those incisions. The main artery, however, which we take is the breastbone artery or the internal mammary artery. And this is like a mechanic which works under the motor hood. When we raise the bone and then we take this artery, as you can see here, and then use that to bypass the most important artery in your heart called the LAD. Heart-lung machine is our friend, and what it really does is it does two things. It essentially, the name is explanatory itself. So the lung component is oxygenation and the heart component is pumping. We also cool down the body so our requirement goes down, and it protects all the organs very well. And you can see here the machine. This is how the machine looks like. So we have really three important components. One is the cardiac anesthetist, one is a perfusionist who is running the heart-lung machine, and of course the surgeon who is doing the operation. So we can stop the heart quietly, operate, do this fine anastomosis with magnifying glasses which we wear, and then take you off from the pump and close the chest again. So this is just to show you the aortic pipe and the venous pipe. Then we open the artery at a desired place, and here it's the Lima artery, which is on the LAD. And if we are using veins, you can see here again, extremely fine anastomosis, and that's why we like magnifying glasses for that. And finally here, this is how the end product looks like. Like in this patient had 6 bypasses, while on the right side, the patient had 4 bypasses. So again, it depends on how many branches we are going to bypass. This is just to highlight that every patient is not same. We can also do beating heart surgery, and there are some centers who do beating heart surgery all the time. We use some special equipment, what is called as a shunt, as you can see, and a stabilizer, because just imagine the heart's moving constantly. It will be impossible to perform a very fine anastomosis. So what we have is a stabilizer of the surface, and then the anesthetic component becomes very important here because they are managing your blood pressure at that time. So we do selectively these procedures. There are some centers who prefer these procedures, and in the science, of course, there's a lot of debate on which is better and which is not good. This is just to show you that if you have a single problem on one vessel on the left side, this can be done through a beating heart from the left chest, as in this patient. And this is essentially looks like the incision. So if it's only on left side, just one vessel or two, you could go from the side of the chest. Of course, again, the debate is, ribs hurt more than the midline, so benefit for that. And there's every year we have 3 major meetings in the world where we debate this since last 20 years, I know. Now, how long these grafts last? That's a really critical question. And you can see here that the internal mammary, which is the breastbone artery, tends to last longer because it's connected to your vascular surface already, and it is artery, so it does the same work as it was doing before. Similarly, the radial artery from the forearm tends to work better. Vein, of course, it depends upon the quality of the vein, age of the patient, and it also depends upon which vessel you are bypassing. That means right side, left side, which branch, etc. So usually the trend is in younger patients, we tend to use more arterial grafts. Gastroepiploic artery from the stomach was used a lot in Japan and then in Western centers, but slowly the use has gone down because they don't last that very well and they're very complex to take. However, if there is no vein in the leg or there are other problems with the forearm arteries, then this is one of the conduits which we sometimes use. Now, factors affecting it, as I mentioned earlier, quality of the vessel, which vessel, progression of the disease. That means if a patient has a successful bypass but continues to smoke, those bypasses are going to go down earlier. So I think managing this, and we are going to discuss it a bit later about what is called as a tertiary prevention. You need to invest in your own health because we can only sort out the problem at this one point. It's not a cure. Complications are really uncommon. This is our data from London where I used to work before. And you can see that the reporting which we had to do This is with all the risks of the patient. These are not low-risk patients. Some of these patients are urgent. Some of these patients are emergency. So you can see that the mortality is extremely low. We do get bleeding slightly more sometimes in bypass surgery because some patients who are urgently operated are on aspirin, clopidogrel, their platelets are not working very well. But the reopening rates, that means patients going back for bleeding, is still extremely low. We get atrial fibrillation in around 80 to 30% of patients, but all these patients usually convert to normal sinus rhythm by 3 months. These are some special situations. Again, I'm showing you this because it's not uncommon. Every year we do around 10 to 15 cases of this. If patient has had a myocardial infarction or a heart attack and it has healed by scarring, that scarring is weak, so it balloons out essentially. And when it balloons out, it's an ineffective pump, but also forms a nidus for clots. This is one of my patients, which you can see we have opened that balloon and pouching, and then I have closed that hole with a patch here. And then this is going to make the ventricle more effective pump. This is one of the biggest operations we ever do. This is called a VSD or a hole. If the heart partition ruptures in the middle, then it becomes very mushy and the blood flows from left to right. And then we have to operate a lot of these patients as an emergency. Of course, there are some advances now. We can use something called as an impeller or an ECMO to stabilize these patients to allow some scar to form so that our stitches hold better. So these patients tend to have quite long ICU stay, but I would say very proudly that our results here in even these patients is 70% survival. In worldwide literature, it's usually 50%. Recovery after surgery, usually 1 day in ICU, you start mobilizing by day 2, day 3. This is really critical. And a lot of patients get surprised. Even I get surprised after 27 years that, we do such a major surgery and patients are walking around. And then by day 4, day 5, they've done the stairs and they're ready to go home. So it's really important to understand that although it's a major surgery, recovery is very fast. Problems are very predictable. So the whole team is already involved. They are aware these problems can happen. They pick up these problems quicker and fix them fast as well. We see you at around 4 weeks. This is the time when we assess your incisions, how you are doing in general in life. And then more importantly, a lot of patients go part-time back to work, depending upon, of course, work. And then by 8 weeks, you're back to normal. There are a lot of common questions in terms of what should I lift, driving. Some patients actually are very glad that they don't have to do any vacuum cleaning anymore in the house. So, but this is something we emphasize a lot. We want the breastbone to heal fast and quick and not give you any chronic problems such as pain in future. Now, lastly, but more importantly, tertiary prevention. I think CABG is not the end of your treatment. It's actually beginning of the benefits. So I think we have to look at it like that. So maintaining healthy weight, control your diabetes, cholesterol, healthy diet. If you're a smoker, quit smoking. And more importantly, remain active. I think these are really important components of enjoying the benefits after such a major operation. Thank you.
So thanks again, Vinnie. That was an amazing overview of the entire field. And as you mentioned before, bypass is a great step, but it's not the end of it. It's actually the beginning of a new life, but you have to be careful because things can happen. Either your native arteries can get worse or the bypasses can close up. And as the time goes by, then the vein grafts especially are more likely to close up and cause problems. So early after bypass is less common, but as time goes by, the vein grafts may start closing up. And what do you do when that happens? As you heard before, we don't do repeat bypass in most cases these days because it's more invasive, so we try to do balloons and stents in many of those patients. And those can be especially important when the patients come in with unstable angina, with heart attacks, because the bypasses start closing up and then they start closing up again, and then eventually they may get completely blocked. But we do have a lot of ways that we can prevent this from happening. And a lot of these things depend on you, on people who had the bypass and actually take the necessary lifestyle and medications. So early on, it's important to control the risk factors, to be active. So again, if you do the same things you were doing before, well, guess what? You're going to have the same result. And once this happens after you have bypass, the options are much more limited. But then as you go further along the course, and now after 10 or 20 years sometimes, those bypasses start closing down, then there are some options that we have right now. And these options are both in medical but also in stents. We do know that if we open the native arteries, that's better than opening the bypass grafts in many of the patients. So we now do procedures like this one, in which the patient comes in and has a bypass graft that's closed. We will open immediately the bypass graft so that there is no damage, not much damage on the heart muscle that's fed from this artery. But then, because these bypasses are not going to last very long, then what we do is we have the patients come back after a few weeks and try to open the native coronary artery. And by doing that, then we have a better chance of this not being a problem at staying open in the long run. So bypass is an amazing treatment. It's been evolving over time. We do have excellent results both in the operating room and afterwards, but it is not a cure-all. It's not the end. As you heard, this is not a finish line, but that's a beginning line. You do get a new life, but if you don't take care of it, then you're going to have a problem in the future. And yes, we do have options. We do have new techniques. We can take care of a lot of those issues with balloons and stents, but the best thing is to take care of them yourself so you don't have to come back to the cath lab and have balloons and stents in your heart. So the key message here is that bypass is great, but you need to do your part, exercise, eat healthy, don't smoke, take care of your blood pressure, your cholesterol, so you don't have to come back and have any other issues. And saying that, I think I'm going to stop here, and we are going to get some questions that we can answer with Dr. Bapat. All right, well, Vinnie, again, that was an amazing presentation, and the audience came with some questions. And maybe we'll start with the first one, which is about the complications. Which one is the most common complication of a bypass procedure?
So during the hospital stay, the commonest complication is atrial fibrillation, that means irregular heartbeat. But as I said earlier, 18 to 30% of patients get that. After all, we have opened the heart, we have put sutures on it. But all the patients generally at 3 months, their heart rhythm goes back to normal. Long-term complications, I would say mainly infection of the wound or things like that, but they are becoming rare because the vein or the leg, from the leg we take with endoscopic harvest. That used to be the major complication actually, but now we don't see that commonly.
And I guess for the audience, this is not the same as the AFib you get naturally out there, because that one has blood thinners involved for a long period of time, even lifetime. So this is AFib is temporary.
It's a temporary AFib. It happens in all the heart surgeries. So that's actually the commonest complication.
And then what is the prognosis? Can the people live 8, 10 years or longer? How long can someone live after bypass?
Excellent lifespan. We see that most of the patients live at least, it all depends upon how your ventricular function is or the heart function is. So for example, if someone comes with good heart function and has a bypass surgery, which bypasses are working very well, and as you have pointed rightly, if some bypasses even go down, they can expect a life expectancy of 2 decades or even more than that.
So bypass doesn't mean you're going down the drain. On the opposite, that you have a good perspective.
Absolutely. So in fact, we have improved the blood supply to the heart now. So once you get over the hump of recovering from the operation, you're actually better than before. So it's better prognosis than before.
Exactly. People will feel better because now they don't have the angina and the other symptoms that had before.
Absolutely.
Next question is about the lifespan. You mentioned in one of your slides about the average lifespan on the bypass graft. So how long do you expect the Lima? I mean, is it going to last forever? I mean, the vein grafts, what is your average estimate about how long these grafts are going to last?
So if we use arterial graft, mainly Lima, which has been shown to be, the best conduit, but it's also lasts longer when it's anastomosed to the best artery, which is LAD, as we know. So it's a permutation combination. But usually speaking, we expect that a Lima will last at least 15 years, if not more. Many times, as you know, in our practice, patients come back for a valve surgery later, and you always see that the Lima is always patent. Similarly, with radial artery was used in 1976 and was given up rapidly because it used to undergo spasm. But these patients came back 12 years later for something else, and they found that now it's widely open. So now radials last around 15 years has made a big comeback. We know how to treat it better. So as I mentioned earlier, in younger patients, etc., we tend to use them. Veins usually can be disappointing after 15 years, 10 years, but again, that depends on the quality of the veins. We have seen veins open even after 15, 20, 25 years. So again, 5 fingers are not same. So we try to use more arterial grafts now than vein grafts, but wherever vein is needed, it's actually used. And many times we prefer vein as well because vein is very forgiving. So if the artery has a diffuse disease, the vein actually works better than if we put an artery.
Just from the patient's perspective, I'll tell them, you let your surgeon choose what's the best bypass for you because it's not just a single factor. There are many parameters, the quality of the bypass, the quality of the native vessel, and can make the best choice about what. But you are using more arterial, and in the long run, that seems to be doing better.
Absolutely. And we also get, especially at Abbott Northwestern, the leg gets scanned. So we know the diameter of the vein as well. So that's very critical. It's not that because there is a vein, we always use it. So we do quality checks, so to speak, on the table. And if we are not if we are not happy with it, we don't use it. We choose an alternative conduit.
Well, Love, I think that's what you said before about GPS, right? You don't go blinded anymore. Before you go in, there's a huge amount of planning that goes in. Right. I think for many patients who sometimes they get frustrated because they have to wait a day or two, well, it's well worth it, right? Because, I mean, if you know that this vein, for example, is not of good quality, then you do something different, and that's going to have a huge impact on their long-term outcome. So absolutely. Planning is well worth even if it takes a little longer.
Absolutely.
Now, next question is about any situations where bypass may not be advised. Are there any cases in which you don't think that offering surgery to a patient is a good idea?
I think so. We face those situations now. As we know, patients are living longer. So again, age becomes a cutoff sometimes. If patient is extremely elderly, we would rather explore, a complex PCI option. There are certain situations where the risk of the patient is very high in terms of kidney disease, liver disease, morbid obesity, for example. And if we can use the modern technology, which you are specializing in, it at least allows patient to recover from this. And then at a later stage, we can optimize everything and then think of bypass when needed. So again, as I mentioned earlier, it has become a team approach. It's not because you're a cardiologist, you do stenting, and I'm a surgeon. We look at all these three things, and there are certain 8-10% of patients who are referred to me. I would say, let's not do a bypass now. Let's explore other options first.
Absolutely. We had a similar common patient lately that we didn't think that surgery. So it all depends on the patient and what is the risks and benefits, right? For every procedure you take into account, and you're right, you get now these 90-year-olds, probably for 90-year-old surgery, bypasses might not be the best option.
Absolutely.
And then another question that very often comes about exercise. How soon can the patient start again light or moderate exercise? You saw they can walk in a few days, but how long do you advise them to wait before starting to exercise?
So we have an excellent cardiac rehabilitation program. I think that is one of the best things that has happened in cardiac surgery. They usually give you, I always say, supervised exercise regime, and then slowly by 8 weeks, you're back on track. Between 4 and 8 weeks, it again depends on patient. Some patients want to go, I always say that don't go 1 step ahead and 3 steps back. So it's not that the bone is going to break or anything. It's just that the pain can set you back a bit. So give yourself 4 to 8 weeks for sure, and then you are back to normal. You can do what you want. You can lift heavy things. It's not going to cause any problems from the incision point of view.
And people are asking, can they do weightlifting after bypass? And they can, right? Once things heal, they can still lift weights. I mean, not 1,000 pounds, but yeah, they can still do their exercise.
Absolutely. And we change medication sometimes. So I think, again, that's one of the considerations for driving. I always tell my patients that it is better that when you start driving again, have somebody with you. There could be blood pressure fluctuations. So just give yourself time to recover from it.
So how long do you actually tell them to wait? Is it a month, 2 months before they drive after bypass?
At least 4 weeks. They should wait. Yeah.
Okay. So the bottom line is it's a major operation. Give your body a little time to recover, and then you will be in better shape than before and feel excellent.
Absolutely.
All right. I think there are some questions that came about risk factors.
Yep. So again, we did discuss, and this is your domain more than mine, is sometimes as a surgeon, you have done the surgery, we feel this is end of my work. So we hand the patient over to our colleagues, which are cardiologists. So what's your advice in terms of lifestyle, regular checkups? A lot of patients have those questions.
Yeah, no, great point. And we, as you know, here we have a very collaborative approach. So even after the patient leaves the intensive care unit from the surgery and they come to the floor before they go home, actually the cardiology team comes in and helps manage the patient, and then the medications and the post-operative care. And then typically we do see them within a month after the procedure. And then it depends. After that, many people are doing so great, then you see them every 6 months and then once a year, which is the typical for coronary patients. Now, if there's issues with atrial fibrillation or they have some other comorbidities, they may be a little more than that. But most people, they feel so good that after the first month or two, as you said, they do so well that they're doing good, that they don't need very intensive care. Having said that, though, for me, this is the golden window of opportunity because the patients just went through a major procedure and they don't want to go through this again if they can. So I think their motivation for things like smoking, diet, exercise, compliance with medication is really, really goes up. So this is the point to emphasize that, look, this is you control this. It's not up to something outside you. You have not everything, but you have a big say on how things are going to go. So if you understand that if you exercise, if you take your medicines, keep your blood pressure, keep your weight low, you're going to be so much better off than if you just go back to the previous lifestyle that sometimes was not as healthy.
Yeah, and it's not just well-being, right? All these things, as you mentioned earlier, affect the patency of the grafts. So again, it's an internal benefit and external benefit as well. Exactly. So I was very curious after your presentation is, now we have got so many complex advanced tools to open these grafts. So what are the technological advances in cardiology field so that our reoperation rate is really drastically going down? And
yeah, absolutely. Thanks. And actually, the bypass patients do remain some of the more challenging ones we do because they have extra difficulties in getting through, and their arteries often, because now it's been a long time and they're quite old by the time they get to us, getting through those arteries can be a lot of problems. So we do have new technologies in going through the completely occluded arteries, new devices for getting through these blockages, which are 100% quite often, new devices for calcium to crack the calcium and stretch those arteries, which sometimes are very restricted. We do have now things like lithotripsy, new forms of lithotripsy, and we also have a lot of devices that are coming up for hemodynamic support. So if the heart is weak, we can put these devices in that help stabilize the heart so we can do the procedure. It's kind of a mini heart-lung machine or heart machine. And then we can do a complex procedure without necessarily putting the patient at as much risk as they would be otherwise.
I mean, I think that has been wonderful, especially in some of these urgent cases, where in old days you would worry about doing a prolonged procedure. But now because of tools like Impeller, you can do it better. And again, we are very fortunate to have Dr. Brilakis and his team doing a lot of research. So any other research at molecular level or something we should know about?
Yeah, so there is a lot of studies, both at the early stages of bypass and then the late stages of bypass. There's a lot of solutions to try to improve the patency of the graft. There has been some genetic modifications. There is things that you may have heard about DuraGraft, some solutions that can help prolong the patency, reduce the oxidative stress. That can be done earlier on during the procedure. There are even some studies in which you image those grafts with either angiogram or now with CAT scan, and you can see how things are happening early. And now we're more likely to give these blood thinners, these antiplatelet agents than before, which I think also may reduce the risk of early closure. And then when it comes to later on, 5, 10, 15, 20 years later on, then it depends on the quality of the graft. There are things like the no-touch technique, getting different types of grafts. There are these seats for the grafts. I mean, there are things that you're probably more familiar with than I am that can help make the impact. But from our point of view, the biggest thing is keeping an optimal lipid levels, giving the aspirin for life, having a good lifestyle and having the exercise, and then having the options, if the patient develops any problem, to come back and take care of this. But from your standpoint, I mean, you've done more research than anyone I know in all sorts of cardiac surgery and the post-op care. What are you most excited about in the future?
So as I said, the surgeon's role used to be more technical, and again, increasing the lifespan of these grafts is really critical. And I think this is where our area is at present. And you could divide it into two ways. One is exoskeleton or supporting these grafts from outside. Because of course, for example, when we take the vein, it is actually doing a work of artery now. So we want to train this vein, so to speak, to behave like an artery. And then the second is the inner layer. That's where the molecular research is going in terms of when we take the vein out and implant it, can we make it as good as an artery? So I think these two areas, it's a slow progress, but definitely there is a progress. So it's not just technical anymore, but it is aided by this kind of research plus the pharmacological, advances which you mentioned to prolong the bypasses and their lifespan as well.
Absolutely. And I think a big part of this is the expertise. I mean, you have an amazingly experienced team in dealing with this that plays a big role as well, because as you say, this is a very technical procedure, and these arteries are so small, you need the magnifying glasses to be able to see them. Actually, I went to the operating room, I'm like, where's the artery? I couldn't see it, because in the cath lab, we magnify them so much.
Absolutely.
So again, I think the expertise is huge and speaks tons to the work that you and your team are doing. Do you have any final works that you would like to share with us?
So all I want to say to the patients is don't be apprehensive. 30 years ago, 35 years ago, this was a major operation. Now it's not just a more predictable and reliable operation, but it's a heart team approach. So when we advise you an operation, it means that we have really discussed it together and we feel it's the best way forward for you. And you don't have to worry about it because we just don't stop thinking at the surgery itself. We have also thought of what I call as lifetime management for you. So it's not just the end of the road, as you mentioned. It is actually beginning of a good investment in getting better. And most of the CABGs we do here predictably discharged day 5, which I find is remarkable and very quick and return to normal life.
Wonderful. Well, again, thank you very much to all of our attendees for joining this afternoon. We appreciate your participation. Thanks again, and have a great rest of your day.
Thank you.